I'm going to introduce Brandy, who is a great speaker and is very knowledgeable in this content area. And I just wanted to share that Brandy is the program manager for the Gender Clinic program at Maine Medical Partners and the Barbara Bush, which is a part of the Barbara Bush Children's Hospital. She provides assessment, therapy, coordination of medical and mental health services, as well as program development within a multidisciplinary setting. She's also a clinical assistant professor for Tufts University School of Medicine. She received her BSW and MSW at the University of Southern Maine and is currently pursuing a DSW from Capella University. And I just learned this about Brandy. She's originally from Georgia, which I didn't realize. So fun fact. All right. So welcome, Brandy. We're looking forward to hearing.
Well, thanks for having me, Stephanie. Stephanie and I just got to hang out for all day training last week that we spent several months collaborating on. So I'm like, oh, this is a different thing. This is a new collaboration that we have here. So which is exciting to be able to continue conversations with new people, as well as folks you've been working with. Just a quick question here. How long do you want me to talk? How long do we want to have questions?
I mean, I would say we want at least 15, 20 minutes for questions, I would guess. So you've probably got the floor for the next 30 or 35 minutes.
Perfect. Just you gotta social workers, and you can tell I'm a big fan of social work, getting all of the social work degrees. So I'm very invested in social work, but that does, it won't take you long to figure out that I can certainly talk about all the things all the time. So I'm gonna share my screen though, so that I can get right to it, because I'm really interested in seeing, what questions you have for me. So let's see. Oh, I just lost you all. I gotta do my thing so I can. I have to set it to a certain mode and then I can still see you all.
We do see your slides though, Brandy, so that's good.
Oh, good. I just got to see you because I'm making eye contact, right, with the folks who have their cameras on. So your nonverbal cues are helping me figure out if I'm communicating or not. And if somebody looks confused, then, hopefully I respond to that appropriately. And if you have a cute dog or something or cat that pops up, or child that comes in, I'll be scanning for that as well. So let's see. So I'm just going to talk about the Gender Clinic. That's the focus here, is what is this Gender Clinic? What are we doing anyway? It's interesting. I was just in a meeting with somebody from Lincoln Health, and I was like, I'm going to Lincoln Health right now. Gotta leave, gotta go to the place here. That person was not a social worker though, so they won't be in this meeting. Let's see. So you already got a little information about me, but I'm very into social work. I'm currently the president of NASW Maine for I think another 2 months. So one of the things we've done there is we have I don't lead it, but I supported the development of a school social worker committee for social workers in Maine. So if you want to connect with other social workers in Maine outside of, Lincoln Health area, that might just be another place for you to find some resources. Let's see. And I think these are the goals for today. So we're looking at what's the Gender Clinic and what's the team do? So if I can't get those objectives covered, then we're struggling. There are 2 gender programs in Maine. I think that's important to know. So the Gender Clinic, our claim to fame is not being the only people. We started our program with early collaboration with the Boston GEMS program. So the Boston GEMS program was the first pediatric gender program in North America. They opened their doors in 2007 as an official program. we're not that far from Boston. We had some collaboration. Our patients were going down from Maine to Massachusetts after a few years. We'd have them transfer back here after they had their evaluations there. We decided we could start developing our own program. So between 2012 and 2015, we developed a program. And so that's sort of that origin piece. And during our time of our development, the Northern Light program in Bangor has also developed a program there. And so part of our work, I think, has been to help champion their success as well. They're a smaller program, but they are following the same guidelines that we're following. They operationalize a little differently, and they have different team members, but there are 2 places for pediatric gender care in the state of Maine. And I think we're all taking that very patient-centered approach. So the one here in Portland, as I said, that's just a picture of Maine Medical Center. That's not actually the gender clinic. When I made this slide, I need to update it. We didn't have our own building. We actually were a virtual program, and I think my office has been in 4 different buildings over the years. So just lots of moving around. Our medical director is Michael Dedekian. He's a pediatric endocrinologist, and then I'm the program manager. So what do I have here? So in terms of background, I think our program, that's one of the things just to know about gender care in general is that there are a lot of limitations in terms of like research and evidence-based practice. And so we are just really very engaged with a lot of different ways to look at, looking at, potential areas of research or areas of research that we've contributed to, and really being on top of the Pediatric Endocrine Society and the American Academy of Child and Adolescent Psychiatry, and who else? WPATH. I'm a certified WPATH member. I think I'm the only person in Maine who's a certified WPATH member, which probably why I can't say the words. I just need more water. So really high commitment to really like following whatever the best practice is, although it's not always clear. So I think that kind of leads to why we have a multidisciplinary team. And so part of that is because we're working with vulnerable people, vulnerable populations, children and adolescents. A lot of them have comorbidities. I think 70% of our patients endorse having anxiety. Actually, 74% last year endorsed an anxiety disorder, and 70% endorsed having depression. We didn't diagnose all of those. That's just how patients were coming into us. Fair number of folks with ADHD. I think 20% of the folks coming in report either having an autism diagnosis or that they would like an assessment for autism. So we are looking at really, really complex groups of young people coming in, high acuity, a significant number of patients. 40% is kind of the number of frequency for suicide attempt, lifetime suicide attempt for trans people, and many people, their initial suicide attempt is in adolescence. So we're looking at probably 20 to 30% of our patients have had a lifetime suicide attempt already before, at the time they're coming to us. I should say we are supporting folks right now up to age 26. So our population, we've extended up from 18 to 21 to 26. The role that our team has, the reason we have a team, a multidisciplinary team, is because that is how the guidelines say, hey, you should do this as a team. So there's the guidelines and guidance from the Endocrine Society and WPATH, but also because of the complexity, and it's just better to hold those things together. And I realize that a lot of you are working with young people, and you may feel more isolated. So I do encourage people to build teams, as you have done here, to make sure you're recognizing, the additional supports around you as you're supporting the young person. I think is really important, because it can be just very overwhelming sometimes. When we look at our team, we have, we're providing assessment, recommendations, or often we'll say referral for medical treatment, but really that kind of is, is this an appropriate medical treatment for this individual at this time? We provide ongoing consultation and support to our patients. Our model involves shared decision-making to the degree possible. So I would not say, I don't know any medical program that would be able to say they partner with their patients completely, but I think we do a good job of making sure everybody who's involved in a decision is involved in the decision, and we don't have folks who are kind of left out. And that does involve a lot of the mental health provider doing the making sure everybody's voice has been heard. We have, we feel that the function of the team allows for improved outcomes. I think we are seeing, it's really been lovely as we've extended our age to see older people who are coming to us with, if one more person needs me to write a letter about their cat in college or for dorm or something, but it's like, wow, like this person has known me for 5 years. We meet every 6 months. And this is the biggest problem happening here is like, how can I be successful at university? I feel like that's a really good success. And so I think there's a lot there to thinking about, I'm not writing cat letters all day. I'm just reflecting on, sometimes it's nice to have those questions that are like, actually, all of the things that we've been working on are in a good place. And I'd like to focus on these other future oriented goals and dreams that I have. And I just really have appreciated anecdotally seeing that with our patients. Let's see, I'll talk about the next thing in a minute. So our approach is everyone referred to the gender clinic. So you make the referral. One of the last slides tells you how to make the referral. So you make the referral and that person is going to meet with me in a group orientation via Zoom. That's going to be the first appointment. So they're going to get scheduled for this group Zoom appointment. We've been running those since August. They're going really well. It was taking too long to do individual orientations. We were just waiting. People were waiting too long for an appointment that wasn't giving them what they really needed. So it's a balance. So they'll get scheduled for an hour group, which is psychoeducation plus question and answer, plus there's an add-on time for individual confidential questions. After that, if somebody chooses to move forward, we're going to schedule them for a mental health evaluation with either a child and adolescent psychiatrist or a clinical social worker. So we'll do that. That's usually, I like to prepare people, that's going to be about 3 appointments. So we are not going to have a one for a young person. We may be shifting our model for adults, but for a young person, like we are not going to have all of the goals figured out on the first appointment. So please don't expect that of us. We really want to take the time to understand the history and background, incorporate any notes that are sent. If there's a note from any of you that you feel would be useful to include with a referral or to have a family share with us, we definitely want any additional information. But we want our second appointment to be just with a young person with no parent. We want to really be clear that that's really important to us to get to know that young person. And then for minors, we really need to find out what the parents' goals are. And we need the young person not in the room for that. So we want to make sure we've heard everybody's voice before we have a treatment plan. So that can take a little bit of time. We have our own process too for determining medical support. So we're not going to assume from the beginning that folks are going to get one medical treatment or another, but we're going to assume that by the time we've had these few appointments, we know what their goals are. Are we looking at medical treatment as a goal? If so, then we can start exploring puberty blockers, gender affirming hormones, or surgery. We don't provide surgery in our program, but we can provide the mental health consultation that is for a surgical referral. And then the medical piece, right now we have pediatric endocrinology and adolescent medicine providers, and we've been collaborating for a few years now with an adult reproductive endocrinologist. So looking at, kind of medical consultation and assessment, if that's indicated. So what a takeaway here is a lot of gender programs have a medical assessment as the first or the second appointment, and we wait until that is clearly identified as part of the treatment plan. And that, it doesn't take that long to identify it, but we're not going to make an assumption that a medical treatment plan is necessary for someone. And then our team has a weekly it's a combined administrative clinical meeting, with all of the folks I just mentioned, plus our, nurse and medical assistant and administrative staff. We also have a chaplain on our team. So our chaplain provides support to the team and also can provide some consultation to patients. And then we have a clinical ethicist as part of our team. So we do a lot of discussing things that don't have clear answers to decide if we're going to, if we're going to proceed with something. A lot of times if we're going outside of the guidelines, then we're going to bring in more conversation to decide, is that really equitable? Are we doing something for this patient that we wouldn't do for other patients? What's the situation here? So just exploring that as a team. I mentioned the guidelines that we follow. So let's see. So this is the WPATH guideline, is that pink and blue book. The guideline was published in 2011. So it's changing. The world has changed. So that is our core guideline. And the 2022 is the year we hope that version 8 comes out. And we're looking to that. And when that happens, we're gonna revise our program to incorporate standards of care 7, 654321 have all been based primarily on expert consensus, and we're expecting standards of care 8 to have more evidence-based information to support the recommendations. And then we have the Endocrine Society guidelines, which is very specific to medical care. These are both available online. Anybody can access them. They're not behind a firewall. So they're all, information that you or your patients could look at. I'm not gonna say it's easy to read, but I'm just going to say it's available to look at it if they are looking to understand something. I think that's really important for transparency, that people know, like, these aren't secret guidelines. The current state of the program, we do have a dedicated location, which is new in the past couple of years. We're in the process of remodeling, so it's a really weird spot over here. The waiting room is like a basketball court size, and then we have a couple offices on the side, so it's a terrible use of space. It's been great for COVID. We've been able to distance quite well, but not so great for appointments, so we're in the process of remodel. We're getting about 40 or 50 referrals a month right now. So, and we have not had a specific increase in staff, whereas 2 years ago, we were getting 20 referrals a month. So we are providing care, I think, more efficiently. And I think we've actually reduced our wait time from when we had lower numbers of referrals based on some of the steps that we've taken to be more efficient. But I do hear a lot of people say that they're waiting all the time, or that the wait is too long. So I do question what's a reasonable wait. I think sometimes people expect us to be there as a crisis management, and I would never refer to any healthcare clinic as your crisis program. We need to utilize the resources at schools and in communities. And so patient in crisis is not necessarily going to merit we're not going to necessarily be able to work with that person faster, and we don't start hormones treatment on people because they're in the middle of a crisis. So we are always going to take the time to get to know and understand what treatment goals are. So I think that might be a place where you all are managing expectations for people on, this is important to you, and let's get you the resources you need, and what can we do today? We have a fair number of folks with some parental conflict. I'm sure you're experiencing that as well. And so our stance is that we do involve all decision makers into whatever the decisions are. So if someone has a legal decision-making right, then we want them involved in the process of informed consent, which involves conversations and documentation. So that is important to us. That means sometimes we end up talking to guardian ad litems. Sometimes we have parents, we may have to have the appointment twice because parents aren't always able to be in the same room. Sometimes plans take a little bit longer. Sometimes parents go to court. Sometimes parents decide, I'm going to step out of the decision making. I'm going to let somebody else, like the other parent is going to make the decision, but we can clearly identify that they had that was their choice to do so. So we've got some ways to negotiate that, but it is, we are not going to be a place people will ask sometime like, oh, can we do this and not inform dad because he'll be upset? And it's like, well, that feels a setup for everybody. Does dad have a right to be upset? So, let's explore what the concern is. Is it a safety risk, or is it, is it uncomfortable, or you just haven't come out yet? Sometimes that's the case. So we want to make sure we make a plan for whatever is going on. We've also been encountering a lot more young people referred to us who are questioning their gender, who are not, who maybe, we actually have a lot of folks who don't meet criteria for gender dysphoria. They're just questioning their gender. We're still going to work with them, but that's also part of why we're not jumping to medical appointments. We really want to make sure we've helped people through whatever those goals are. Let's see, this is a picture of the referrals that we have, right? So you can see 2021 was quite a large number of referrals compared to some other years here. I've been running the program, so all of these people I have personally communicated with. And this, if you can't see the number on the side, this is up close to 450. So it's this number here, whereas this number here is closer to 250. So it's a big jump. This number way down here is around 80. And at that point, the program with the resources at that time was completely overwhelmed. So we just continue to organize and become more efficient. Let's see, I included these slides. I think I was just talking about this already, so I'm not going to just explain the mental health evaluation again, but just to note that the follow-up, we do not provide weekly therapy. So if your patient just needs a therapist, we are probably going to be disappointing to everybody because you're going to wait, you're going to get an assessment and evaluation, and we're going to see, we're going to say, well, let's see you. We're going to, ongoing follow-up might look like 3 times a year or twice a year. It's not going to look like every other week for 6 months. When we're able to provide that level of support, which we have been, like we had a new provider. So while their caseload was increasing, we were able to provide some therapy. Sometimes we plan, part of the treatment plan is 6 weeks of therapy or, something very specific. So I'm not saying we won't see people more frequently, but there's usually a very specific target of we're going to work on some family work here and then get you back to resources in the community. Or maybe there's some gender exploration, but it feels like something we can do in a certain number of sessions. It's not exploring, we're not doing psychodynamic psychoanalysis, exploring. We could do that. We'd love to, but that would take a long time. You're going to lay on the couch and figure out who you are over 5 years. But you could, those are certainly services you can get in the community for people who are motivated for that. We are going to assess something called gender dysphoria, which is a mental health diagnosis I'm sure you've all heard of. It is, the basic definition is really looking at the distress someone has because their gender identity and the sex assigned at birth don't match. But, we are, of course, looking at the DSM-5, which has many, many words to describe gender dysphoria and explain that. So we are looking at it as kind of a broader diagnosis. A lot of people will say I have gender dysphoria, but I think people also say I have anxiety, I have depression. So that self-reported experience versus, where's the distress, who's experiencing it, how, what does that look like? Can we talk about it? Does a person have insight? That kind of goes more into that diagnostic piece. Let's see, just preparing folks for the medical piece. As I said, that is coordinated from the mental health evaluation process. We'll bring in a medical provider if needed. For folks who are at the very beginning of puberty, this is key. These are the only patients that I want to see faster. So if anyone's at the beginning of puberty and they're your person, so maybe you're working in middle school and that person is starting puberty and is experiencing distress related to that, I really want to work to get that kid in sooner because even if our wait is 3 months, we want to buy some more time to explore with this kid before we're making decisions and to get to know what's going on. So that patient is one I would say, call me and leave a confidential voicemail, letting me know, I want you to know about this referral, name, date of birth. Please keep an eye out for this referral. And this is the situation about puberty. So I just want to, that's the only group of patients that we're gonna kind of move a little bit faster to make sure that we get them in. So the medical evaluations, like what are we doing anyway? For kids who've had no changes in puberty, we don't do anything. So they don't see a medical provider. There's no reason to really talk about medical treatment other than to just say like, those are possibilities for the future. I'm not going to help a parent of a 6-year-old figure out if their kid's going to have surgery in the future. That's, we just want to figure out how to be 6. And that's just about maybe some social support. So a lot of times we'll get referred younger kids. We just see them a couple times. We might even do less of an evaluation. We might just see them and then they're connected. Sometimes people just want to feel like, okay, we were there. If we need to come back, we know the door is open, and that is totally fine. And we might just see those people once a year. I've seen many people once a year, and then we suddenly were like, okay, now we're seeing, repeat appointments. So that is totally fine, but I would just set people up like that might just be a one-time 1 or 2 appointments, and then kind of come back in the future when you're ready. For folks who are at the beginning of puberty, we could be looking at medications such as puberty blockers, also called pubertal suppression. So these are medications that stop puberty where it's at. Nothing is reversed, but also nothing continues. It just stops. They're considered partially reversible. So they are considered fully reversible because once you stop the medication, puberty continues. That does not mean that's not without controversy or careful consideration. There are a lot of factors here, but essentially that is the basic information of what that treatment does. For adolescents and adults, often folks are looking for like menstrual management or suppression, which is a service you can get from your local primary care provider or an OBGYN. You do not have to come to a specialty program for menstrual suppression, but that is something folks will come to us for, and we're happy to provide that level of support. Also, androgen blocking medications that are for people whose bodies produce testosterone, but they're kind of past puberty, but that ongoing, maybe they're not ready for gender affirming hormones, but there's something there that can be relieved. And so there's some medication that mostly affects hair and skin, but can be prescribed. So that's something that our providers will prescribe. Gender affirming hormones, that would be testosterone and estrogen. So probably the bulk of referrals are people who are looking to medically transition, and that's what they mean. And then again, gender affirming surgeries being something that we do not provide in-house, but we collaborate with providers within Maine Health if we're able. Most of the folks for gender affirming surgery are not in Maine Health, so they're going out of, actually most of them are going out of state, unless it's certain kind of plastic surgeons who are within usually in private practices. So that can be a little bit tricky, but we're providing the mental health consultation for the surgical referral, which is sometimes one mental health provider, and sometimes it's 2. So you may have already provided this, maybe somebody's ready, but they need another mental health provider and they have to be a different discipline. So one has to be like a social worker or a licensed counselor, and then the other would be like a psychologist or a psychiatrist. So you have to have, for the 2 letters, you need and you do slightly different work for each of those, but it's you need both of independent assessments, and we can provide that in the gender clinic as needed. Let's see, I mentioned our team. I think I already shared this. I apologize. I saw the team, the other slide I made, and I forgot I put this one in. I let people know that the team is for me your patient's not going to come before our team as a panel of experts to decide what their treatment is. So we're just looking to support each other. I'll tell patients, this treatment, this whatever we're doing here sounds like I think it's really appropriate for you. Although it's a little different than how we would normally do things, I'm just going to go talk to our team and I'm going to come back to you with some feedback and let you know what they've shared. And then we're going to integrate that into the care plan. So it's not as though the team isn't making decisions on it's not like a transplant team where they decide who gets what. It's just to provide additional support. So it's not like a group of people behind a curtain who are deciding that. We've incorporated things and said, so we understand that would be the recommendation, and now we're going to do something different, but we've provided that information to the family or the young person, and that would be the medical and the mental health provider are the ones who are making decisions with the patient and family are the ones who are, assessing them specifically. We're also offering parent support groups right now. I'm not offering patient support groups at this time because there's several in the community. Probably you and Lincoln Health, I would recommend you reach out to Out Maine. Their focus is rural youth support for LGBTQ youth. So that's their goal, is to support kids who are not in Portland. They will support kids in Portland, but their goal is to support the rest of Maine that's not in like really York and Cumberland County. So, and they've been doing great online groups. So that's something you could choose for your individual person. But we do have parent support groups for any parent in the gender clinic to come together twice a month right now is what we're doing via Zoom, and helping them support each other, because I feel like sometimes they don't know where to go. And so for the people, it's a self-referral for parents, so they'll choose to opt in. And I think the people who opt in, it is what they needed. And then a lot of people don't need the support. So it's really, we just let people select if they need it. I have 2 slides here that are just about the how to make, if you are in Epic, you have to make the Epic referral. And let's see, I don't know why I wrote this extra. Oh, some providers can do an Epic referral. The next slide has the internal. But we do have on the website, there's still a form up that people can check. We can accept a referral from somebody who's not a primary care. We just really prefer the primary care referral because we have to often go back for insurance. Even if we don't, it just streamlines things. But we do recognize that there are times when that is not possible. There may be patients who don't even have a primary care provider, so we're comfortable taking referrals from others. But ideally, we want to get the primary care provider to send that over. Again, leave the confidential voice message on my phone if a patient is in puberty, early puberty, because I want the heads up on those patients. And then if you're in Epic, this is the numbers and letters you need to know. If you do not put in the referral department, it gets lost into the referral abyss. It's like sunk in the mud somewhere and it goes nowhere. Almost all of the time, every time somebody says we sent a referral and this person's been waiting, almost always it's because they didn't put the department in. So it is a 2-step piece. So if you are checking on your referral, obviously go check and see if you put that department in before you call us. Because if you call me, I can go and find it. I can pull it out of the abyss, but I have no way of knowing it was there. So we definitely want to help people not have longer waits, because our system is weird. So you'd think it would anyhow. I did not build Epic. Just a couple resources for you. Maine Transnet has a peer support network, largest in the country, actually, largest peer support network for trans people. Equality Maine, they're your LGBTQ advocacy folks in Maine. And then SAGE is really when we're looking at working with elders, which they're part of Equality Maine, but just like to think about broad buckets. There's lots of other resources out here. I believe that ends my show. I hope that answered the questions you wanted me to come and answer, and also left good time for questions.